All right, good morning, everyone. Good morning. I am Robert Agnello, and I have Kathleen Farrell here with me, and I will introduce us, and we'll get working here today regarding de-stressing pain management. It's great to have you all here. I'm just gonna, before I introduce us, I want to get you thinking potentially about patients and cases that you have that have opioid use concerns, chronic pain, that you will come up to the microphones and present to us and to everyone else that is here so we could go ahead and discuss them, okay? And that'll make this really fun 90 minutes. Otherwise, we're gonna be really bored and just looking at each other, okay? So please think about those cases. So before we move forward, I would love to introduce Dr. Kathleen Farrell. Dr. Farrell works at the Veterans Administration in Pain and Substance Use Clinic. She works remotely for the San Antonio VA. Before becoming an osteopathic physician, she worked for several nonprofit organizations that serve people who are on substances of concern. She graduated from the Arizona College of Osteopathic Medicine in 2002. Her concern for those who use substances continued when she exited residency in 2005. And she started using buprenorphine in her practice in 2006. Her first practice was in Idaho with Valley Family Healthcare at a federally qualified health center where she did inpatient and outpatient care. So this is important. Dr. Farrell has a lot of experience. That's why I wanted to kind of go back. Myself, I work at the Campbell University School of Osteopathic Medicine. I'm part of our Department of Family Medicine. I worked for Fort Bragg, which is now Fort Liberty, from 2010 to 2022 before I joined the full-time faculty at Campbell. I worked in the Integrative Pain Management Center and did a lot of pain care for about 8 years there, and also managed soldiers and retirees that were utilizing opioids, having some concerns with opioids. So that's some of my background. I also have done integrative pain. I've done some functional medicine training, and I am acupuncture trained as well. So sometimes that's what I bring in to the care for these patients. So first of all, what I want to show you is this. If you have not signed up for our ACO, sorry guys, it's like automatically advancing on me. Stop there, okay. If you have not signed up, take out your phones right now, flash that QR code, and it will take you to the ACOFP, ACOI combined program on de-stressing pain management. Guess what? It's free. It's 5.5 hours of free didactics. Now, it's not just us talking to you. It's been wonderfully integrated with many different learning styles, and you could go ahead and see, here are the main lectures and topics that are part of the program. Okay, so if you can, I don't know what I did, but this keeps advancing forward on me. I don't know if somebody could help. But I must have clicked a thing that times, I'm sorry. So there you go. So those are the topics. Again, it's free. I start off with the basics of pain, and we have a lot of other faculty that help to work through the rest of the modules. They're awesome. I've had the opportunity to review all of them, and they are really, really fantastic. So please sign up if you didn't do that. It's in that QR code. All right, without further ado though, let's go back, and I will turn this over to Dr. Farrell to get us started.
Good morning. I'm really thrilled to be here and to see everyone, and I am looking forward to hearing some of your stories as well. Just to let you know a little bit more about me, I do have a certification in addictions with AAOAAM, and I work for the VA remotely now, but I have worked in the office. I've worked essentially in pain management and opioid use since 2018. That's all I do in my practice right now. I basically get people to safer places with their substance use. And a lot of people in pain management are on opioids. I do use a lot of buprenorphine in my practice. I also have to let you know that since I work for the VA, that none of my opinions reflect the VA. They're my own opinions. So, but they're from experience, and it's from what I see works. So to start it off today, what I'd like to do is have someone present a patient. What we need is their relationship to opioids and their pain diagnosis. And it can be a hypothetical patient, it can be based in your reality. We don't want to, cross any privacy lines here or HIPAA violations, but we do want to start talking from our own experience and see what we can do to treat these patients, how we might manage them differently. Pain management has been very dynamic. It has changed incredibly since I've started medicine. What we have learned and known and our studies are contributing to what we can do today. And I don't know about you, but I feel like some of the guidelines have really failed us. And we actually have to think outside the box a little bit when we look at some of our patients. So I need a brave soul here to come up and give us a case. Thank you.
Hi there. I'm a practicing physician in a small town in Illinois, and I'm inheriting a lot of patients who have long-term opioid use and long-term benzo use, and some of the diagnoses are adequate and some are not. And so a lot of these patients are in their late 60s now, gonna go 70s, 80s, and I'm also thinking about the long-term, what I can do to help get them off some of these drugs, but then also what is the best pain management for older populations.
Okay, let's turn that into a case, okay? So give me like a 63?
Yeah, 66-year-old male, long-term history of chronic back pain, and has been to interventional pain management for a long time, didn't help with any of the things, has been on Norco 10s 3 times a day for at least 20 years, and then is on benzo, mainly the Ativan, I would say, 0.5 to 1 milligrams at least twice a day.
Okay. Okay, so I'm going to have you stay there for a little bit. What kind of questions would you like to ask this patient? And we need you to come up to the microphone so the people that are seeing this session virtually can hear you. So you are all my partners. You didn't know that, but you're all my partners. So we need to work together here and try to figure out how to treat this patient. 63-year-old with a chronic back pain on Norco. What would you like to ask this patient? Does it work? Is the Norco working for this? That's a great question.
Well, he thinks it is, but he also is not ready to come down to see if it's...
Okay, we need to come up to the microphone.
Have you tried injections?
Tried injections, okay.
Yes, he did injections and he also had nerve ablations.
Okay.
Is he motivated to get off the prescriptions?
That is a hard no.
How about this one? Does he feel like he needs more?
No.
Okay.
I have one for you. What is his function and quality of life like on this medication?
He's functioning very well, and his quality of life is good. Like, he does all his activities that he wants. He's now retired. I think he's just very anxious about changing anything.
Okay.
What?
Is his UBS positive for hydrocodone?
Yes.
That was positive for positive for hydrocodone in his urine.
Mm-hmm.
Positive for any others?
Just the medications he's taking, so appropriate. So the Norco and then the benzos.
So you're not worried about drug diversion? Mm-mm. What state is this?
Illinois.
I know, is it, I have a question for the panelists. Mm-hmm. Is this based on state? I know the DEA is a federal organization, but are there different state rules? I know there's different PMPs, prescription monitoring, but Are you one with a PMP?
Yes.
Yeah, there are different state rules that you have to be aware of. There's the basic DEA, and we are required to do 8 credits of anything in pain management or opioid use or substance use.
And we're happy to say this counts for one of ours, so we're excited. Thank you.
Yes. So, but every state will have its own rules. You know, like I know I think it's in Kentucky, if you use buprenorphine, you can't use buprenorphine for pain. It has to be for substance use. So you got to know things like that. Where I am, I can use buprenorphine for pain or for substance use. Most states will emulate what the federals say about doing 8 hours, but some states might say you need, like Washington State says, you need to do 2 hours in a long-term opioid, you know, like extended use opioids. So there's little variations.
Yeah.
Any other comorbid conditions such as COPD, respiratory diseases, something that will make the opioids worrisome?
This specific patient, no. Do I have others in my practice like that? Yes.
Okay.
Let's leave it to this.
Any other pain meds?
I believe this one occasionally also does some muscle relaxers, but it's rare. Maybe like twice a week or twice a month, really. But otherwise, that's pretty much the medications he's on.
Which muscle relaxers? Are they controlled or not controlled?
Not controlled.
I might have missed this, but why is he on the benzo?
What is the reason for the benzodiazepine?
Yes, that's for his severe anxiety and issues with sleep.
When did that start?
That started way before I got him, I would say in his 20s.
Has he seen a psychiatrist?
Yes. And he does not want to go back.
What's the issue with continuing the narcotics since he's functioning great?
The question is regarding continuing narcotics.
So my big question is, how safe is it to continue this if we, one, don't know if he'd be better at a lower dose, and two, kind of planting the seed with him in our initial appointment is, what are we going to do in 10, 20 years from now, and how safe does that look?
How long has he been on opioids already?
20 years.
20 years? 20. Okay, so I think this is really a great case because it actually illustrates a lot of issues. One is the patient's, what's our definition of stability here? He's doing okay on it, he's managing okay, but he has COPD?
Not this one, no.
Oh, he doesn't have any medical issues like COPD or CHF. Okay. One of the things I wanted to do was to write, like, so that we could kind of follow easier and see what was said before. And that's ahead of this technology, so we can't do that. But you'll find we're ahead of technology here a lot in what we're doing here. So I might have to re-ask questions to be sure I understand right. But
So I have one curiosity of the whole audience now, and somebody yelled it out. Are we happy where we are? Do we do anything? So we're going to move on this. We're not just going to raise hands, and we don't have polling software because it's never terribly reliable. Those of you that think it's acceptable with what you know now for this patient to stay on the opioid and the benzodiazepine, stand up. Commit. Who thinks it's okay? Come on, commit. If I don't see everybody else stand up for an opposite answer. Okay, thank you, you could sit. Who thinks this needs to be absolutely changed and this cannot continue? It's pretty close. All right, sit down, and who's kind of uncertain and wants more information? You can stand up, and then you have to ask a question. All right, Dr. Pennings. Dr. Pennings, because he's my chair of my department. Please come to the microphone.
Well, what I would find is the most challenging in this case is the patient is not motivated for change, right? So how do you work with that patient to either, identify is there any internal motivation for change, or you know, are we going to be kind of stuck at this point? Because you may want him to change, you may want him to come off the medication, but if he doesn't want to come off of the medication, that's going to be a constant conflict as if you continue care there.
Thank you, Dr. Penning. So you stay there. Now, who is absolutely committed to yes, he can stay on what he's got? Who wants to come to the microphone over here and talk about it's okay? Please come on up. Thank you so much. This will be fun. And then obviously, where am I going with this? Somebody who's in the no camp, please go to that microphone. So we have the maybe team. I want more info. And now we have, why do we have to change things? Go ahead.
Well, this gentleman is functioning fine. He's not abusing the situation. He's using his medications appropriately. And if you look at the division, it seems to be age-related, okay? The people that say no seem to be below 40. The people that say yes are above 40, okay? So the people above 40 have a significant more experience of utilizing narcotics when they were more readily available and less intrusive by the DEA. So it's an experience situation. The one caveat I have is access by the prescriber, because we're having lots of issues with ortho, surgical, post-surgical, pain-related situations where by the DEA regulations, we can only do 5 days max, unless they go to a pain management specialist, of which there aren't enough ever created. And that's why a number of the orthopedic surgeons are bringing lawsuits against the DEA to open this up a little more.
Now, don't go anywhere. Where's our no person? Please come on up. Represent your group.
So these are legacy patients, and they're very tough to treat, and the poor doctor's got a lot going on, but she doesn't have a leg to stand on benzos and opioids. So you got to get something else. Ooh, feedback, I like it. Got to get something else for that anxiety. So, you know, the hydroxyzines and the Vistaril, but he's got to be motivated, a little Elavil at night, reasonable. You know, as long as he's under the 90 MME, we're decent. The guy's only on 10 or 30. Great question on, you know, he works, he's productive, he's not selling it. We do urine dips, and I think the caveat on urine dips, don't do the oxycodone in the office because, you know, they're synthetic, so they won't show up. So, and I'm glad he's not on marijuana, you know, the Acapulco Gold like we have in California. But anyway, not a leg to stand on with the benzos. Gotta get off, black box.
Okay.
Anyone else would like to come support a certain camp? And as you can see, we could probably talk about one case for 8 hours today, and I guarantee, but, okay, go ahead.
I can comment on needing more information, just like I understand yeah, keep them, they're fine, there's nothing, whatever, but I like the idea that she's trying to look ahead 10 years, right? Look down the road, because if you add another 10 years to his treatment, then he can say, well, I've been on it for 30 years, right? And so that in his mind, that justifies why he should continue it. So I think using motivational interviewing, getting to the root of the problem, why don't you want the change? Well, it's working. Well, if we found something else that was working, would you be willing to change? Or, you know, a lot of other medications have been tried in the past, and I don't want to go through all the pain and the suffering and the issues again, right? So using your motivational interviewing to kind of get to the root of the problem and see if you can say, well, here are my concerns from years down the road. As you age, your body changes, your interactions with those medications and everything. And with benzos, it's going to get even harder to get off of them the more time he's on them. So again, you're trying to see, like, can I make those changes now? That's where it's like, it's not a hard, fast yes, it's not a hard, fast no, but it's like, we need to work together and come up with a plan for the future.
Okay.
Okay. So for me, it's the inheriting a patient that's on a whole list of medications, and they're on it just because they were on it. So I've been on it 10 years because no one took me off of it. And every new doctor that I got, if something happened to my other doctor, I'm just on it. So you have a long list of medications that they're like, yeah, I'm on it because my other doctor put me on it. Okay, so what's the reason? They told me to take it. So I'm now getting like looked into and looked over for continuing medications just because. Opiates and benzos being like some primary ones, like, oh, I get that for sleep. Which one? Because they'll make you sleep internally or eternally. So like, let's think about why we're on these things, and being on it just to be on it is not the reason. Because you had surgery 20 years ago, or you fell off a tree when you were 6 years old and you have pain, and now you're on like 40 morphine meal equivalents of opiates plus your sleep aid, which is a benzo. And now we're getting, like the younger people, your charts are getting reviewed, you're getting audited. Why are you on this? We're gonna give you a report of how much you're giving people, when you're giving it to them, if they're compliant. Have you tried to taper them down? Have you had a meeting with them? All this stuff to keep them on this medicine. It's getting ridiculous. So it's like, that's why I'm like, okay, well, let's look at this. Why are you on this? Do you need to be on it? Just because you've been on it doesn't mean you should be on it.
Thank you so much. Okay. Any other, Dr. Pennies, any follow-up from?
Hold on, one more.
Oh, we got one more.
Okay. First of all, the idea of the older doctors being separated from the younger doctors, I'm an older doctor, and I absolutely, this patient needs to be changed. Okay? So bottom line is, there's so many issues in this with us. Think about your physician liability, too. If this patient, something happens to this patient because of these drugs, you may be liable. The family may not be so agreeable as the patient has been taking these medications. Number two, you have the issue of benzos and the morphine or the opiate. This patient is at jeopardy in the long run. As this patient gets older, he's 60 years old now, he's going to be 70 next time. And you're going to have a patient that is going to be at more risk of falls, all kinds of different issues. Constipation, falls. This patient needs to be changed.
Thank you so much. Okay, any other follow-ups on this? Dr. Pennies, you good?
So, I totally agree with what was just said, and that was my concern too, is what are we looking at down the line? What are the long-term consequences? And is the patient aware of those long-term consequences? And what are their thoughts on that? And trying to identify to see if there's any underlying motivation for change. That's what I would be looking for in that patient.
One more comment behind you there.
I'm sorry, over here. I have a microphone over here. Yeah.
Oh,
hi. My big problem with this is lazy management of anxiety to give people benzos. And this started when he was 20, so this was 40 years ago. Enough is enough. He really needs to be taken off the benzo, and there are a lot of different medications besides hydralazine and Visceral that can help with anxiety and actually manage these people in a much better quality of life. So we just have to get this guy off a benzo and get him on something for his anxiety.
So I want more information, and my information I want to know is, what's he been on or tried in the past for his anxiety because of the benzo, and what was the reason why he didn't continue it? What happened? Half the time they don't even remember. They can't even tell me their name of the medicines they tried, and they can't remember what all happened. All they know is that they didn't work, and I'm back on it. So that's why I'm still want more info.
Okay, I'd like to say, for one thing, there's no right or wrong answers here, but it's important that we establish a relationship with the patient and that we understand what the risks and benefits are to change or keeping it the same. Some people might feel comfortable keeping benzos and opioids on the same patient if it's a very difficult patient. But then you also have to realize that having a benzo on board increases mortality by 35%. So you got to keep that in mind and also inform the patient. And trying to change patients' minds, it really doesn't work saying you just need to do this because it's the state law or my administration is making me do this. You do have to approach it from where the patient is. And you got to look at what their personal health risks are. And now this patient didn't have any personal health risks, but let's say a patient does have severe COPD and is on morphine that can affect the respiratory centers. Maybe they need to make a change for their own safety and make an appeal to them for that. You know, I'm really concerned because people die on opioids. And they don't die just because they overdose. There's very few overdoses in prescription opioids, and I can show you some, if I can get the slide there, some mortality. Can we get this mortality slide up here so people can see it?
Yep, it's there.
Is it up there? Okay, it is. It's up there. Okay. So the crude death rate in the United States is like 9.8 per thousand. And it did go up a little bit in COVID. It's somewhere around 9 to 10 per thousand now. And that's just overall mortality for everything. It's not just opioids, it's for everything. The crude mortality rate for patients on prescribed opioids is 28 per thousand. So by just putting people on opioids, we're increasing their mortality, their chances for mortality here at an earlier point. They're also, what we see in the data is that maybe 1.1 is an overdose. So it's not that many overdoses for prescription opioids. And what patients think is that the only people that die are those that are taking it wrong. And they think that since they're following our directions, they're not going to die on it. Well, they can die just because they're on it, and they have to be educated to know that. And that they are increasing their chances of mortality just by being on the opioid. And I didn't get into all the other drugs, but by putting benzos on board, you're increasing mortality another 30%. Antidepressants increase mortality by another 10 to 25%. Muscle relaxers by another 12%. Gabapentin increases mortality by 15%. So if you have a person on a multi-substances, their mortality, the rates get higher and higher. And we have to educate patients to let them know what the risks really are. So if a person's, you know, like I do have some difficult patients that are on opioids and benzos. I am getting them to safer places, but it's going to take me time. I can't do it. The patient's not going to accept everything right away. So there is a plan to get him off the benzos, but I have to work with him in order to get him there. So some of the things we do just to show some other mortality rates here. The mortality rate for OUD is actually less than prescription opioids, 18 per thousand. And it's 6.4 overdose per thousand for overdosing. On agonist therapy, this can help us out too. These are alternatives. You don't just have to take someone off opioids. You can actually put them on another opioid that's safer for them. With methadone, it takes the death rate down by 17 per thousand. If you use methadone and start people on it, the death rate's up front with getting them on the methadone. So it goes up to about 30 per thousand. But once you get them on the methadone, the death rate goes down to about 12 per thousand. So you do cut down their mortality rate there. Buprenorphine is 7 per thousand. That's even better than the overall death rate in the country. And you know, some of these studies, the studies that I got these on just came out. And I think with time we'll have more, but I think perhaps in general we have younger patients on buprenorphine, and maybe that's why it's down to 7 per thousand. So it's just kind of things to consider and think about when we're coming up with treatment plans. So there are some people who are going to want to get the patient off the benzo. That would reduce mortality, get people safer. Another option might be putting that patient on buprenorphine. That would get them to a safer place. And if they can't get off their benzo, maybe they need to stay on their benzo. It's safer with the buprenorphine. You know what I'm saying? It's like we should take the patient's views in mind, and then we should try to work with that patient to get them to a safer place. Not necessarily the ideal place. We'll get some to the ideal place. We're not going to get everybody to the ideal place. but we'll get them safer, if that makes sense. So, so anyway, so hearing all that information, now what are we thinking? Do we want to change this person off benzos? How much do we want to go for it? Do we want to, are there other options people see for treating this patient?
One thing I'll just throw in too is, you know, the benzos are hard. Benzos and withdrawing somebody from benzos can be fatal, just so you know that. Taking people off opioids, there really are no documented deaths from opioid withdrawal. So realize that too, if you're really kind of being pushed into some decision making with the patient. Realize too, in 2016, we all became very afraid, right? The CDC guideline basically came out and said, you can't have people on opioids and benzos. They've kind of retracted from that a bit in the 2022 guideline, where it talks about a very nice individual, like we have for everything else, like the prostate and things like that, individual decision-making opportunity. Okay, so realize there has been some changes, and we shouldn't necessarily feel as handcuffed and shackled as we did 6 or 7 years ago. Just wanted to throw that in.
Thanks. So 2 thoughts. One is getting this patient, what do they want to do in terms of, do they want the opioid or do they want the benzo? So we're focusing a lot on, they have to get them off the benzo, but maybe they'll come off the opioid, and really using that to try and figure out, meet them halfway. So which one would you choose if you had to choose one of them? Maybe a way to come through it. The other thing is Suboxone and buprenorphine, Butrans. I love it. Every time I try and prescribe it for some of my high-risk patients as an alternative, I think it's Medicare or Medicaid says, no, you have to use OxyContin or MS-Contin.
Yep.
And it's like, what the F, okay?
Yep, that's exactly right.
Haven't you gotten the memo?
They have not.
That they're gonna, I'm putting them at risk of death, and why aren't you letting me prescribe Butrans? So I don't know how do we leverage our collective power to change the system to let us use safer opportunities and to cover better things like physical therapy, biofeedback, acupuncture, OMT, so that we can actually use a lot of these other modalities. So that's my 2 cents.
Sure, yeah, I see that I have to educate everybody around me a lot of times, especially when I use buprenorphine, because a lot of people are confusing it as just another opioid. People just should be off of them, period. And there's a whole bunch of points of education in what you were saying. One is that just tapering people off, you're putting them at more danger of mortality than if you just left them stable on that opioid. So that's something to think about. If you taper, you're actually increasing risk. Now, I'm not saying you can't taper, because I do taper. There's some patients that they want to taper, that's what they want to do. But I'm in constant communication with them. I go very low. I go lower than what the guidelines are saying, because I didn't find the guidelines worked very well. So I'll cut pills in half and have them, and taper for 3 months on the same dose and go down very slowly. Because I found that just works better. And I use my staff as my barometer. If my staff is going crazy because the patient's going crazy, I know that I'm going too fast. So I either have to cut down the dose, make it a lower dose to go down on, or extend how long the taper is. And it's taken me years to taper people, literally years.
Yeah, I was going to say I love all the additions to the different modalities and therapies that people are using. I think that's wonderful, and they should be doing that and give that to their patients. As far as for the benzos, I've had some wonderful experience with our atypical antipsychotics. Odds are this gentleman's probably an undiagnosed bipolar disorder. So, using the atypicals, especially if he has insomnia issues, for the sedation, you can use those. They work fantastic. Hopefully he's on an SSRI or SNRI. Hopefully he has had a trial of gabapentin or Lyrica to help with his pain. But definitely I am pro getting him off the benzos, getting him off the narcotics, absolutely.
Yeah, and I'll just say, I actually love tapering people off benzos because I find them more successful, but okay.
I had a question about looking at tramadol and buprenorphine as the mixed agonists, antagonists,
Okay.
and we are so concerned now about getting patients addicted to opioids. And I think everybody in this room has probably seen hundreds of patients who clearly got addicted even though they did what they were supposed to do.
Okay.
I haven't seen a whole lot of patients who started on tramadol or buprenorphine act addicted. I haven't seen any data on it. But my experience tells me that if we start with those for pain, it seems like we're less likely to get the problems, not only with the overdoses and the interactions with other medications, but even with creating an addiction in a patient.
Okay. First of all, I want to finish up the benzo discussion, and then we'll get on to the tramadol discussion. I just wanted to say with benzos, I've had a lot of success with getting people off benzos. And I do the choice thing, you know, do you want to work on the opioid or do you want to work on the benzo? That gives, whenever you can give patients some choice and some options, they buy into the treatment plan more. So I do try to come up with options for people. The other thing is that you can taper the benzo very slowly, or let's say they're on gabapentin or pregabalin. I leave them on the gabapentin and pregabalin. I taper them off the benzo and the pregabalin, and this is not in the literature, it's not studied, but it works really well. If they're on gabapentin or pregabalin, they don't have any seizures. When they come off the benzo, they get off the benzo, they're doing okay. And then you can go after the pregabalin or gabapentin. The other thing was tramadol. Tramadol is kind of an interesting drug, and there's more and more coming out of it. It's actually more dangerous than we think it is because it's not a good combiner. It does not combine well with antidepressants. It has more like a TCA effect on the serotonin and the receptors there. So we got to really think about tramadol. Tramadol is not as safe as we think it is. And I've had people majorly addicted to tramadol. It's been very difficult for them to come off. Buprenorphine, they never crave it. Tramadol, they're going to crave when they get off. Buprenorphine is weird, but people can come off of it safely. They'll crave the other drug they were on. They won't crave the buprenorphine.
I'm going to add to the tramadol discussion because I personally find it vile. They're not going to. So first of all, when they first sold it to us when I was coming into practice 20 years ago about what a safe option it was, they didn't even really know what the mechanism of action was 20 years ago when it came out. Then they realized, ooh, it affects the mu-opioid receptor. Ooh, it affects the adrenergic system. Ooh, it affects the serotonergic system. So now you're dealing with one medication that is working on 3 different pathways that makes it so nearly impossible to get people off of. It is the most abused prescription medication by medical professionals, tramadol. When they end up in programs, look it up. Tramadol is the medication that usually is the problem in people like us because it was such an innocent, wonderful thing for us to use. I've had people who have had seizures. I have had people who've had all sorts of interesting things happen using tramadol. Other thing, I just want to correct this because we're medical professionals. No more narcotics. We talk in opioids and opiates. We're not lawyers, we're not judges, we're not police officers, okay? Let's dump narcotics from our terminology. Let's not teach our students it. Let's not teach our residents it. Opioids and opiates. And the other good piece of information to know too is what are the morphine milliequivalents daily or ME? That's changed 1,000 times too. It's better to kind of figure out, are they on 40, 60, 80 a day? And I agree, I want to go back to the point what Dr. Farrell said. The recommendations will say you could decrease this by like 10% per every other week or month. We've gone as low as pretty much 2.5% a month, and it might take you 3 years to safely get a patient off of an opiate. Or what I've seen happen a lot is I get patients down to that very last nighttime oxycodone, and they won't let it go. Stop! You've brought them down probably from 90 morphine milligrams to 7.5. You should be very, very, very happy. And everybody is safer and should be jumping up and down and doing a dance. I wanted to throw that. We do have a case from virtual land.
Great.
But great, thank you for that example, and we'll keep speaking. Let's queue up the virtual. How do we do that?
I think you have to read it out.
No, it just says we have a new case from the virtual platform. Go ahead.
It will be read from this side, and it's now on the screen.
Okay.
And it reads as follows. I am a family medicine resident in Waco, Texas. My case is as follows. For HIPAA reasons, some details have been changed. 30-year-old female patient with PMHX of sickle cell disease presents with sickle cell pain crisis. She has been in and out of the hospital 10 months out of the year. She uses 160 MME daily at home, Dilaudid, PO, 2 milligrams Q6, oxycodone, 10 milligrams Q3H, PRN. The patient does not follow up in clinic. Question is, when do you start the discussion that they may have an OUD while still being cognizant of their underlying condition?
Wow, that's awesome. And I'm just going to make a quick point, and I'll turn this one over to Dr. Farrell in a second. One thing, opioid use disorder, very easy to diagnose, right? There's 11 criteria. You only need 2. If somebody's on an active opioid, withdrawal and tolerance are 2 of the 11. Guess what? You have opioid use disorder. It's mild. Okay, depending on how many positives you get up through that 11, you can reclassify from mild to moderate to high. I'm sure she's got more than those 2. So yes, you probably need to formally make the diagnosis of opioid use disorder. That's my thoughts there. But Dr. Farrell, go ahead.
Yeah, and I've had the opportunity to kind of look at things a little differently. I don't find opioid use disorder very a diagnosis that will allow the patient to interact with me in many cases. Because a lot of my patients are pain patients. They've been trained as pain patients. They don't speak the OUD language, and they're actually very insulted if you give them the OUD diagnosis. Yes, there is elements of OUD in some of these patients that have been on opioids for a long time. And what I'll do is I'll diagnose them with long-term use of opiates and have them recognize that, and they usually can recognize that there's been long-term effects, side effects from these opioids, like tolerance. They notice that this patient definitely has tolerance because they're in such a high dose of opioids. Withdrawal. A lot of them are familiar with withdrawal. Another interesting question to ask these people is, when you have pain, when you missed your daughter's wedding, what were your symptoms? And a lot of times I find out these symptoms sound like the COWS score. They were sweating, they were nauseated, they were actually in withdrawal between doses of opioids. So it's just, and that is a side effect of being on opioids for a long period of time. So I will use a pain diagnosis. I'll use long-term use of opiates. The things are changing. You know, FDA, well, they're saying it's okay for us to use buprenorphine, any form of buprenorphine, as long as we document what it's for. And so I use buprenorphine a lot. But you can, like this case, the interesting thing about this case is the patient has sickle cell. CDC, in their guidelines recently, took sickle cell out of the general guidelines. We don't have to consider the CDC guidelines in this patient, like palliative and hospice care. The patient's put under that category. So you got a couple of things. There's a lot to consider in this case. Do you want to use OUD in someone who has kind of, you know, CDC says we don't need to consider these guidelines for this patient here. And yet this patient's in a lot of trouble because they're on these high-dose opioids. And why isn't there clinical follow-up? If this patient's getting a script written for them, there's got to be clinical follow-up. So, you know, I get that patient say, if you want the drugs from me, you're going to have to show up in the clinic. We're going to have to get that UDAS and start talking to this patient in a way that they can recognize that these drugs have interfered with their life, and start working on that. And I would suggest another opioid to them, like buprenorphine. But however, this patient's on really high doses. If you're going to use buprenorphine with this patient, you're going to have to be willing to go above 34 milligrams and justify that. And that can be hard in a lot of areas. We need a microphone here. Can you come up to the microphone, please? Mm-hmm.
If she's really in the hospital 10 months of the year, she may be missing most of her appointments and then unable to reschedule because of clinic schedules. And that may not be getting conveyed to the provider. She may do better on like a virtual type of scheduling of some sort. The other thing is with her chronic pain and possibly her family or, you know, whatever her personal situation is, she may be unable to get transported to the clinic. Or she may have other financial situation that, you know, she may not even have a job because of her chronic pain and be extremely low income. So it may be very, very difficult for her to follow up. So maybe you need to consider some other type of clinical situation for her to be able to get her monthly follow-ups. Because if she's in the hospital 10 months of the year and has sickle cell, I imagine that she may be a low-income patient with very difficult transportation issues and misses all her appointments because she's always in the hospital.
Yeah, good points.
Because I've seen this in the veterans a
Sure.
lot too.
Yeah, and yeah, so have I. I mean, they're all good points, and we all have to consider this. And the whole thing is we might not have the right answers, right? This is going to be a really difficult patient, and you're just going to have to dig in there and be with that patient and figure out an answer every day. You might have to think of a different answer for this patient. But go ahead.
I have a different, well, similar the same topic, but has anybody looked into like the genetic testing for metabolism of opioids, like which which opioids they would metabolize better than others? I know there's a lot of sites that talk about it for like the SSRIs and stuff like that, but has there been anything in your experience about the opioids aspect to that?
Can I answer that question?
Okay.
Yes, there is. There's a company called Tempus that does the pharmacogenomics for all of the SSRIs, and at the bottom of theirs, they'll do tramadol and some of the other medications added to it. So you might look up that one.
What was it called?
Tempus.
Tempus.
Yeah.
When you get that information, you have to be willing to kind of act on that information, and it's complicated. I mean, that was hot. It was a big train momentum forward like 10 years ago where we were doing a lot of that, and it has recently fallen a little bit more out of favor, but it could resolve some of those more complicated cases or be helpful. It depends, as long as you're comfortable with looking and interpreting that information.
One of the things I wanted to point out with this patient that's on such high MEDDs with the Dilaudid and the morphine that they were on, is that sometimes if I use buprenorphine and they're on these really high doses, I have been able to go above 34 milligrams in some of my patients. I've gone up to 48 milligrams, and many times people will do much better when you get them up there. The other thing, though, that happens sometimes is they end up on a combination of buprenorphine and morphine, or buprenorphine. It's like you got to think out of the box. I try to get them off the Dilaudid because I think it should just be a hospital medicine. But you have to get creative in working with these people. And methadone might be an option too. You know, maybe this patient can control the amount of methadone they take. It would get them to a safer place. But.
So that was actually going to be more of my question is how do you do that? Because I've tried to switch someone over to like Butrans and fallen completely flat on my face, really under figuring out like what would be an equivalent. So do you have resources? Like how? I feel like it's harder to find resources in morphine mill equivalents for buprenorphine than it is for other meds. And so I feel like I'm just rolling the dice to try and figure that out. And I don't know if you have any other resources or guidance on how to try and transfer that over.
That's a great point, because when it first kind of came out, buprenorphine, they almost had no conversion tables. And now they try to say that it's 1 milligram of buprenorphine equal to 30 morphine milliequivalents in some tables. And a lot of this doesn't seem to make sense to me. What do you think about that?
Yeah, I have what I have used from experience, because all I've done is put people on buprenorphine for the last 5 years. So I have a lot of experience from what I've seen. And the thing is, people have different definitions of stability. The pharmacists I work with, their definition of stability is just to get them out of acute withdrawal. But it really takes more to get people to where they can live their lives. And I find there's different stages. You get them out of acute withdrawal first, then their mood improves. They just start feeling better even though they still have pain. And then you keep increasing it, and their sleep cycles start changing. They start sleeping at night. And they feel a little bit better, but they still have pain. And you just increase it a little bit more after the insomnia improves, then their pain is good. Their pain is manageable. They may not be all the way out of pain. I never promise to get rid of pain, but what my goal is for my patients is to get them to stop focusing on the medications, stop focusing on the pain, and have them focus on their lives again. And that's my goal. And that's what I can do with buprenorphine. Now, what I find is kind of a general guide for me, because I'm trying to get them to this high state of functioning. It's like 8 milligrams to 30 milliequivalents of morphine. That's what works for me. Now, if they've been under Butrans and Belbuca, they only work up to about 35 milliequivalents of morphine. They don't work at 80 like the manufacturer said in their 12-week trial. They only saw them for 12 weeks. I see them for years. So I want them to get to a point where they can function and not just be miserable, if that makes sense. But there's going to be no data on this. There have been all these conversion tables of 1 to 90, 1 to 30. More goes into those conversion tables. What the DEA was really trying to say to us with that 1 to 90 conversion is that when somebody's on 1 milligram of morphine, they could be on 90, what would be equivalent to 90 milliequivalents of morphine of buprenorphine, and they still wouldn't have respiratory depression. And that's why the DEA took the conversion tables off, because we were saying, okay, 1 milligram of morphine or 1 milligram of buprenorphine equals the 90 milligrams of morphine for analgesia. That's not what they were trying to say. CDC was trying to say to us when they came up with those conversions. So we were misinterpreting the conversions, and the thing in this area, and that makes it like where we are good as osteopathic physicians, is that we actually have to get into a relationship with the patient, connect with them, and work with them on their symptoms. We're really on our own here with that patient.
I'm a rural physician in East Texas, so the closest pain management and psychiatrist is at least an hour away in Waco or Tyler or Dallas. What I've noticed, so I do treat quite a few pain patients. Two things I want to bring up. A lot of people who do drug screens, I've noticed a lot of MDMA positives on my patients, and I question them, are you doing ecstasy? No, but I've talked to our lab director, and apparently if you're on an SSRI, that can give a false positive MDMA. Have you heard that?
There are false positives. I never, with false positives, I always get a confirmatory. You should always get a confirmatory and see what it really is. And there have been times where I've called up a patient and said, hey, look, I got a false, no, I don't say it's a false positive. I got a kind of an unexpected positive here. Can you tell me, is there anything you want to tell me? And sometimes they'll fess up, and sometimes they have no idea. I get the confirmatory, and it turns out to be totally benign, And so you got to get those confirmatories before you really dig in there, start accusing the patient of something.
Right. Number two, if I'm uncomfortable with a patient, I don't feel like it's safe and effective to continue this regimen right now, I try to refer them or they won't go. Obviously, if you haven't heard, there's a fentanyl crisis in America, and people are getting methadone or getting stuff off the streets, and it's not pure, and it's laced with fentanyl, and we're seeing more and more deaths with that. Can you comment on that?
I mean, certainly one of the things you see is in these mixed, one of the things when you try to say, hey, I'm not going to give you the same amount of your opioid anymore, is they're going to find their way downtown wherever and get some kind of illicit source, and it's anybody's guess what's in there, right? And hydralazine is in there now, and all sorts of other kind of crazy positives come out from those. So that's one of those risks, you know, that you're going to find sometimes when you start tapering people down, and sometimes they don't make it back because they're dead, right? Because they go ahead and do that. So that's where you see some of that. When you have your urine drug screens, I just wanted to talk about this for a moment. You have to feel confident about what you're going to do with that, right? I mean, I don't discharge any patients from my practice. Hopefully that's like a policy that's old. You know, nobody has that anymore. Unless they're like rude or abuse or threaten someone in my office, that's not a policy. I'm going to help. That being positive is a call for help. Okay, maybe there's another substance, right? If I'm treating them with buprenorphine, I'm treating them for the opioid concern. I'm not treating them for the stimulant concern or the other possibilities that are in there. And so we need to maybe address 2 different or 3 substance use problems, right? So you might find that, and it's a call for help. Yeah. So I don't discharge patients. I don't know, Dr. Farrell, about your policy.
I never do based on UDAS. It might mean I need to change my plan with that patient. And on the fentanyl question, I use buprenorphine in my practice for everything just about. So I'd get them on the buprenorphine. Even if they decide to do more of whatever they're doing on the street, they're going to be safer because the buprenorphine's on board. When you look at mortality studies, the death rates go way down even when patients are on a combination of drugs if they have buprenorphine in the mix. And the other thing that they're finding with mortality studies is that usually if patients have been on buprenorphine and they wanted to intentionally get high, they go off the buprenorphine and they see norbuprenorphine in the mortality things, but that norbuprenorphine gets counted as a buprenorphine death too. So, you know, they were intending to get high, and so they've been off their buprenorphine for a while. But as far as you're concerned, if you just get them on some buprenorphine, you're just going to increase safety and just keep working with them. And you know, I've had people who do kratom and buprenorphine. They'll only do so much buprenorphine, and then they do their kratom or whatever. But the more they're working with me, the higher the buprenorphine gets. So just take them where they are at, get them to the little step, safer, continue working with them, stay in relationship with them, and it's amazing what they'll do.
More of a question on the morphine equivalence and how it's not really a good tool to use so much anymore. In my practice, I've used buprenorphine patches on some patients who cannot stand the taste of Suboxone, which I've heard it just tastes awful. And I know in America it's up to 20 micrograms now of the patches, but over in Europe, I believe it's safe up to 100 micrograms is what they found. Do you have any experience with using the patches at higher doses for chronic pain?
Yeah. Do you want to? I've done a lot of research on this, but anyway. The ones in Europe, they'll even put like 270 microgram patches on, and they start at 35 microgram. And what happened is in the 12-week studies, there was one patient that had congestive heart failure, and the FDA said that they had to report that. So that's kind of where that all, that's why they limited it at 20 micrograms. But it's probably, I mean, it is safe to put the patch on and have it stronger. You might not want to put it over the heart, directly over the heart. Some pharmacists would have a little problem with that. But they can put it on their upper shoulder, upper back. It's buprenorphine. It's getting through their skin. It is safer in higher doses. It's just where our system decided to put the limitations. If you can talk the insurance company into giving 2 20s if the patient needs it, that'd be great. But we got a lot of education, and we have to educate the people around us that are, the insurance companies and everybody to help support what we can do for patients. But I do find Butrans is very helpful, especially in people who can't keep track of stuff, maybe little mild cognitive problems. And they're good for people who've been on lower doses of opioids. It doesn't really help the higher dose opioid.
'Cause even that 20 microgram patch, maybe if you believe the conversion tables, is 40 to 50 morphine milliequivalents. So you start somebody on 5, theoretically it might cover up to 10 morphine milliequivalents. Then does it really get truly absorbed? What if they sweat a lot? I've had a lot of patients that have had adverse reactions to the patch. Eventually, month after month, they have local irritation, then it's the whole arm, then I've had people have the lips, the tongue, the whole thing, and I could not continue with the patches. So I've had a lot of sensitivity issues with that, just so, I don't think it's the buprenorphine itself. It might have the materials, the adhesives, the other things that they help to make sure that the buprenorphine delivers through the skin might be some of the cause for that.
I am a family practitioner. I actually practice wound care full-time in Western New York. So the majority of the patients that I'm dealing with are actually having acute pain as a result of their wounds. Some of them may be opiate naive, some of them may be on chronic opiate therapy, some may, to add another layer, may be using substances in the street, and that's the reason for their wounds. And one of the things that I think we struggle with in our community is, certainly we need to treat their pain in order to effectively treat their wounds as part of, the standard of care. In order for them to do what we want them to do, their pain needs to be treated. So I guess my question is, what is a good jumping off point? What is a good starting point? We want to be cognizant, we want to be aware, we want to be safe with these patients, but we also want to give them what it is that they need to be able to treat them effectively. So my question is, where do we start? What's a good starting point?
Do you have like an example patient that you could present?
Sure, absolutely. For instance, 54-year-old patient with peripheral arterial disease and an arterial ulcer of the lower extremity, who, for cardiac reasons, is not cleared to have an angiogram of the lower extremity yet. So we're not able to have revascularization of the lower extremity until their cardiac issues are worked up, and they're having excruciating pain, particularly at night while they're sleeping. They have a history of being on hydrocodone, Norco 5 milligrams with minimal relief. That's prescribed by their PCP, and now I'm coming in and I want to help. We do utilize, topical treatments, topical lidocaine, topical medications like that, which of course only work for short periods of time. So what's our next step?
So they're having frequent exacerbations of pain because of those wounds that are non-healing. Are there any other medication strategies that have been considered here, an SNRI or anything like that?
So, I usually try to work with the PCP to kind of come up with that plan. And I think the question is whose responsibility is it, right? So I hopefully am only seeing the patient for a short period of time. I'm happy to treat their pain while they're with me, but what can I do so that they're not, I never want to, okay, now just follow up with your PCP and drop everything on the family practitioner. That's the last thing that I want to do. So certainly those discussions are being had, but whose responsibility is it to start that, and where is it that we go from there?
Yeah, it's true good opportunity for good interprofessional communication, right? I don't know what the follow-up process is like. Is the primary care just going to, hey, I trust that it's going to be in the chart that they come, the next time that they come to the office? I think it's very reasonable to say, write down, hey, get back with your PCP. I think something like duloxetine, right, an SNRI can be a very helpful adjunctive medication strategy here, right? It's indicated for chronic pain. It's working on 2 systems, so that might be something that's good. If there's any nerve component to the pain, certainly you can use those anti-seizure medication strategies within that plan. And then the question becomes, can opioids be helpful in managing this patient too? So there's a lot of other integrative strategies I would probably think of first before jumping to the opioid, but getting in touch with the primary care professional, I think, is really the place to go and have that communication. Do you have any kind of intermediaries, a case manager that helps to get back to that primary care manager in their office?
Not really.
Okay.
It's mainly on us providers to do it, and certainly we're not opposed to reaching out. We have, we're such a tight-knit community that we're not opposed to reaching out, but there's a wide range of responses to that question. There's some PCPs that are like, well, you're treating the wound, you're responsible for the pain management. Okay, well, but I also don't want to start this patient on something. I'm only going to see them for 3 months. I'm going to heal their wound, and then I'm not going to see them, hopefully never see them again. And then trying to get into pain management if that's necessary. We've got a 6 to 8 month waiting list to get in to see pain management. So
Great. Any other thoughts from others?
I'd like to get the slide on risks benefits up here. Yeah, thank you. This is a really great paper, I just wanted to point out. And one of the things it does talk is about wound care and how opioids, full agonist opioids, interfere with wound care, actually. People have more infections, go to the hospital more with infections. But I'll open it up to the discussion. I just want to point out, too, that buprenorphine doesn't have, it's at least neutral. It doesn't interfere with the wound healing. I've actually had patients who were non-healing, put them on buprenorphine, and they healed with diabetic ulcers. I've had patients with pyoderma granulosum. I've had patients with all sorts of really awful wound care, and it seems to do better with buprenorphine. So that's an option, but I probably shouldn't have jumped there. But let's open it up more for discussion, but we also have another question, too. So.
Good morning.
Good morning.
I'm a family medicine physician in my third year of practice and very interested in treating opioid use disorder. But my question is, how much time is spent on teasing out the co-occurring disorders, trying to initially figure out, getting ahead of knowing whether or not what beast you're treating or how many beasts you are treating with the initial presentation of an opioid use disorder patient, and if there's any scales and or evaluation forms that are out there that you guys might know of that might speed up the process.
So evaluating comorbidities like mood disorders, things all of my patients, every visit, fill out a PHQ-4. And I usually will go beyond that, and have them do the PHQ-9 and GAD-7. Looking at depression, looking at anxiety, I think that's pretty easy to do. My nurses administer that. You can bill and code for those. I don't know if anybody knows that, 96127, and usually get about $4 as long as you take action and comment on those depression and anxiety screens. So I definitely use those. If I'm considering putting a patient on an opioid, you're going to use a tool like the opioid risk tool, the ORT. So hopefully you all have that loaded into your EMRs. I use the Defense Veteran Pain Rating Scale. I don't know if you have that at the VA, but the DVPRS, what I like about that, 0 to 10, you have colors, you have words, you have sad and smiley faces. I think that leads to a better idea of where their pain, and then there's 4 supplemental questions, right? And they're going to say, how does this affect your mood? How does this affect your activity? How does this affect your sleep? Okay? And so you can get a little indication of, is insomnia a problem? How am I going to address that, right? So those are other things. I'll use the PEG, the PEG, right? Are you enjoying life? Things like that, to give me some good information on looking at that. PTSD, when I was in the military, we would always do the PCL screening. I would look at pain catastrophizing. There's a lot of scales that you can kind of use and help kind of hone in what directions you're going to go.
Great, thank you.
You're welcome.
And I'll look at what is it going to take for me to treat the patient? How much is this diagnosis going to change my treatment? And I'm going to look at things that are going to keep me in connection with that patient. And in my practice, the treatment's the same. It's buprenorphine. Whether it's pain or for OUD, it's buprenorphine. And I don't have to have the exact diagnosis right on the nail when they come in to treat them. I can still go ahead with the treatment and more will come out. And even like a lot of the patients who are pain patients, they know how to talk to you, they know what to say, so they don't get that OUD diagnosis.
Well, my question was sparked because you had said the UDS, you don't use it as a dismissal, you use it more so as a tool to kind of continue to help with what's showing up positive. So, yeah.
I'm sorry.
You were saying with the UDS that you use it more so as a tool to not dismiss the patient, but
Right.
to find out what else they need help with. So that was what's
Yeah, it's a continuing discussion, evolving treatment. You know, I'll just say, you bring up another interesting point, is a lot of people that I treat will have a UDS that's negative for opioids and they're on hydrocodone or oxycodone or something. And I'm like, what's going on here? Well, they're getting their UDAS right before they see you and they ran out. And they're going through withdrawal every month when you talk to them. Those people are in danger. They're medically not at a safe place. So you got to find a different plan to work with them. Yeah.
One thing I wanted to show, and what Dr. Farrell is making very clear to everybody too, is buprenorphine is an excellent option, right? It's not just for opioid use disorder. It's for chronic pain. It's, if you look it up, it's from moderate to severe chronic pain. I wanted to show you one study that really supports this. And I don't know, anybody ever here been involved with an ECHO model for care? Enhanced Community Healthcare Outcomes? Anybody here? If you're part of the military or VA, you're probably more likely to have experienced this. This is where you build up a hub and spoke model of care. You'll have experts sitting around the table, like Dr. Farrell, pain management, psychologists, chiropractors, acupuncturists. Everybody gets together to talk about the patients like you're presenting to us today to make people more comfortable with migraine management, headache management, whatever the topic is. It actually originated out of the University of New Mexico about 20 years ago for hepatitis C management because of the patients that couldn't get to Albuquerque or they couldn't get to Santa Fe. So a lot of our patients that are in these rural settings that can't get to the pain management people. They did this in Vermont where they started the ECHO program, and you can see really early on the number of prescriptions that the primary care providers in those organizations were willing to write for was almost zero. And then once they started regularly, monthly participating in the ECHO program, and month after month heard about these kind of cases, you can see by the end of the study period how much more buprenorphine prescribing was actually happening, and it maintained. So I think you're going to become more comfortable with the opportunities as you speak about this more, research this more, review this information more, and, shameless plug, go back and listen to the ACOFP, ACOI program where we help you out with some of this as well. So I just wanted to make sure that I showed that information. Go ahead.
One thing that hasn't been touched, and maybe you just started to touch on it a little bit right there, is lifestyle change. These people need a lifestyle change. And getting involved with a lifestyle counselor, the ECHO program sounds like something that you didn't really go into in depth, but it sounds like that's very much involved in that kind of thing. A whole different, this person needs to take on a different lifestyle if they're going to succeed in this. So let's not forget the lifestyle changes that need to be happening in these patients.
Yeah. And there are a lot of interesting studies out there with using psychology, and definitely a lot of our patients do need psychology, and they're really helped by that. But I find that if people are still too much on the OUD side of things, they can't focus on the psychology to get what they need to benefit out of it. So I find that I have to get them stable first so that they can focus on other things besides the medication and their pain to get them to a point where they can accept psychology and use it in their lives. Now, other patients I've had, all they need is the buprenorphine, and they're like, I know what to do. I know what I did wrong in my life. I know how to fix it. And the studies are showing it's better just to give them the buprenorphine than to make them go to the rehab or psychology or anything. Just as long as they get the buprenorphine, they're doing better. So,
and that was a big change in recommendation over the course of time. I mean, originally, when you did start prescribing buprenorphine, that psychological component was pretty much mandatory.
Yeah.
And that's evolved. And you can see even with the updated ASAM provider recommendation, you consider the psychosocial needs, the social determinants of health, all of those other things, but nothing should really, based on what this is saying, get in the way of that medication prescribing.
Yeah, and I'll just say, if to our younger physicians here, Don't be afraid of change. Your practice is going to change in the next 20 years. What we say today may be totally different in the next 5, 10, 20 years. My practice has changed enormously. We didn't know much about buprenorphine in 2006. We were trying to be careful so it wouldn't become the next oxycodone on the street. You know, and in fact, we set up barriers to make it where it is right now, where a lot of people are so uncomfortable with buprenorphine, they don't even want to touch it. And unfortunately, those barriers are getting in our way now of taking care of the patients we need to take care of. So don't be afraid of change, embrace it, it's going to happen.
Yeah, so quick kind of comment question for the audience. Do we have faculty members of residency programs or directors in the audience? Okay, there's at least a few. And I'm sure there's going to be some online as well. So I've been out about 5, almost 6 years now from residency. Our residency practice was do not write controlled substances. If you come to me as your preceptor and recommend a controlled substance, I'm going to stare at you until you come up with a better alternative or something different. So when I actually got into practice and came into the real world and inherited a clinic where the gentleman that I took over for had written Xanax 3 to 4 times a day for every patient who had anxiety, I was woefully unprepared to deal with that because I had no safe methods. Nobody really was able to teach me how to effectively do that. I had to learn on my own. I lost patients to a clinic that would co-write benzodiazepines and opiates. I lost patients to anger from me not understanding their conditions. I lost a lot of patients to that. Got negative reviews onto the clinic because I was unwilling to write them, and it cost the clinic business in the long run, which again, we all are here to do what's best for the patients, but ultimately we do have to make a living and keep our staff employed as well. So that does matter, but that's kind of just a general comment, is that I don't know if y'all all do that, but that was my experience, so please consider teaching your residents an appropriate use rather than none whatsoever. And my question for you guys is, going with more of that route of you're going to absolutely avoid at all possible, what medications do you have to maximize? Do you have to code prescribe? What things do people have to fail in order for you to go back that slide that you had up of where to start? Don't be afraid to initiate, but what things do they have to fail for you guys to initiate medications that would, your opiate class medications?
Do you want to?
That's a fantastic. I mean, we might have a variety of answers for this as well, and that's okay. We are out there, just so you know, trying to spread that whole idea of the model of ECHO to residency programs. Actually, one of the residency program people is right here, Dr. Hill. I'm not going to put her on the spot, but we're working with them right now and a program in North Carolina called NC STAR. NC STAR is basically an ECHO program through Chapel Hill where any primary care physician from the state can call into to get the help that they need to manage these kind of patients. So that's one thing. If you came to me and I was precepting you at the residency program and you came right at me and said, hey, this patient should be on buprenorphine, of course I should have some questions, right? And what should you try them on first? Well, I mean, I think that very reasonable other strategies include, your acetaminophen and NSAIDs, and I don't like to put people on NSAIDs for their whole life forever if I don't have to, because that can hurt things just as much as an opioid can, right? I could put somebody on naproxen twice a day for 500 milligrams, and that 60-year-old guy 20 or 30 years later is going to have a big, massive GI bleed or a heart condition or renal failure. And I can tell you the statistics from last year, 110,000 people died of opioids, 65,000 people died of chronic NSAID use. So we don't want to do that, right, necessarily for the rest of a person's life. So what about an SNRI? Oh my goodness, well, the patient's 72, let's say. Well, if you kind of look, you got to start at the lowest dose, and you got to worry still about age, and even those medications, they're not innocent and go without negative consequences. Tricyclic antidepressants, right? Think, exam board question, Beers criteria. You're not really going to jump into amitriptyline and nortriptyline in a 75-year-old. But if I had a younger patient in their 20s or 30s, military, VA, I would say, hey, you have insomnia, you have pain, a low dose of an amitriptyline might go a long way and not cause that young man to have erectile dysfunction. Put them on duloxetine 60 milligrams, no young man is going to stay on it. Just going to let you know that right now. This is real world clinical experience. Yes, go ahead, follow your algorithms, but that's what can happen. All right, and then finally, what other adjunctive strategies do you have available? Are you in a state that has medical marijuana available? I don't know how we all feel about that, but a lot of the states don't really list it for chronic pain. They list it for a whole other host of conditions and considerations in use. I've seen some people benefit from medications prescribed like dronabinol, but you can't even find that right now anymore because the manufacturers can't create the medication right now at this point in time, right? What about low-dose naltrexone? Maybe for some widespread pain conditions like fibromyalgia. I've had some success. I don't know, Dr. Farrell, if you used LDN much, but I get some great success from 4.5 milligrams of low-dose naltrexone with widespread pain conditions. So I'm kind of working through that, but I'm also throwing at them other opportunities they may have never had. Have you ever had auricular acupuncture? Have you ever had OMT? Has anybody actually put their hands on you for this pain condition for the last 5 years and actually confirmed what the cause of pain is and considered other pain interventional opportunities like nerve blocks, radiofrequency treatments, epidural steroid injections, trigger points, perineural therapy, and a whole other host of opportunities? Sometimes patients haven't even heard of those terms or words. I've had a lot of patients that have never seen the whole health wheel or have had any ideas of how to do self-care and self-management. I've had patients where I've just changed their food lifestyle and have gotten them off opioids. Okay? I've had people who start to sleep better and have gotten off of opioids. I've had people that start to interact with their spirituality and have gotten off of opioids. And hey, if that's 1 in 50, I don't care. That's pretty good for something that's really low risk. So sometimes working through the VA whole health wheel might be something that helps to drive and create change. And that's what I want to talk to my residents about as we kind of work through some of these patients. And hopefully that excites them as much as I do. But getting to the opioid?
I think you can come up with a lot more answers for somebody who's never been on opioids. And they haven't tried a lot of things. You can come up with a lot of different ways of helping them out without getting them on an opioid. I would not want to try and put someone on a full agonist opioid if they've never been on opioids ever before. But I get the patients that have already been through the gamut. They have done the steroid injections, they have done the pain psychology, they've done NSAIDs, all sorts of things. And some of them are not appropriate for NSAIDs. They got chronic renal failure or other issues. So you got to really take each patient into consideration. And if I need to put them on an opioid, I have put people who've never been on opioids on buprenorphine because that's my first go-to. They don't ruin their lives. If they go on buprenorphine, they don't get into the cycles that they do get in on the full agonist opioids. And a lot of times they just need to be on that low dose of buprenorphine, and that's all they need, maybe 300 micrograms of Belbuca twice a day. I have some people on 75 micrograms of Belbuca, and they take it every 3 days. But that's what they need to feel normal and to feel like they can engage in life.
I have a gentleman at my clinic, I'll just share quickly. He had opioid use disorder, self-recognized. I mean, he had problems with it years ago. He had an injury to his ankle foot. What did the orthopedic emerge place come up with? Here, let's put you on some oxycodone for the acute injury that you had. Well, guess what? It reinitiated his opioid use disorder problem. So he showed up. I was so excited. He came to our clinic. He's like, listen, I've got a problem. I know this is an issue. I took them all. I feel like I'm craving. I want to go somewhere else and get more opioid medication. And we put him on buprenorphine. Put him on buprenorphine, and it helped out like 4 milligrams of buprenorphine. All the craving gone. I'm not going to go use anything else. He's doing great. It didn't help his pain at all. And guess what we did? We titrated him up over the course of about a month to 6 weeks up to 10 milligrams of buprenorphine. He has like no pain. He's functional. He works 40 hours a week. He's happy. He's sleeping well. His anxiety resolved. So just a personal, one of my wonderful success stories, and I'm sure you have tons more than of those than I do, but just to share and think about.
I mean, we were talking about patients who are on benzos and stuff before. You get them on buprenorphine, and buprenorphine does have an effect on anxiety. There's a place on the mu receptor for anxiety and depression. Full agonist turns it on. Buprenorphine turns that area off. So a lot of times you get them stable, and you can get them off the benzo, and then you can get them off of the other medications. But we have another. Sir, did you want to?
Yep.
Oh, it's not on.
Oh, there we go.
Okay. I actually have a couple questions. So I work for an organization that not too recently came out with an initiative to get all patients off 60 ml equivalents of morphine or more, or start tapering them. And so it forced us to start looking at some different options. And I did look into Suboxone. And the strategy that we developed within the program was to do like a saturation effect, and I wanted to know what your comment was on that. Essentially, you would max out the dosing of the Suboxone if they were on 60 ml equivalents or greater, regardless of the dosage, and then they would use that, and they would essentially pass that as with all the receptors saturated, that it really shouldn't matter what dosage of opioids they were on, you should be able to stop them, and then eventually start tapering the Suboxone. So I wanted to know if you actually used that strategy and what you think of that.
I'm sorry, I didn't quite get that with the feedback there. They have you stop the opioids and then start the buprenorphine? Is that
so what they would have us do is they would have us take a taper up to Suboxone sublingual up to 8.2, I think it's 3 times a day, while they're taking their opioid.
Okay.
And then after a period of time, have them stop the opioid, and then after a period of time longer, start tapering the Suboxone until their pain was under good control, or as their pain tolerated it.
Gotcha. Okay. So what I do in my practice is, as I taper them off the full agonist, I taper them up on the buprenorphine, and to keep them at a level playing field, so to speak, for their, like, how they're able to handle life. And then the thing is, I've had a lot of people come off of buprenorphine, but I've always let them do it in their own time, because their body seems to know when it's time that they can get off of it. They start sleeping too much. That's the big major symptom, is they're starting to sleep 10 hours, 12 hours a day, and they don't like to sleep that much. They feel fine when they get up, but that's a sign to me that we need to cut back the buprenorphine, and that's often a sign that if I've done it like 4 milligrams every 3 months, and then they're off, and they don't even crave anything. They don't crave morphine, they don't crave oxycodone. But if you take them off the buprenorphine too early, they're going to crave that morphine. They're going to find another doctor that will give them something.
Well, on the patients I have, I think I have like 5 to 10 of them that I've successfully transitioned to Suboxone, but I do have one in particular that was not able to have their pain under good control with the max dose of Suboxone, so we initially agreed to having a low dose fentanyl go along with it. But with any of those, I really haven't got to the point where I'm able to start tapering the Suboxone with their comfort level. How long of a period of time would you expect that to occur? Are we talking months, years, decades?
If these people were high tolerance people, it's gonna be years to get them down. But what I do with the buprenorphine is I dose it for their pain. So I don't stop at 16 milligrams, or I keep going up to make sure their pain's taken care of, so they don't go looking at other places for other things. They're not, and it just seems there's no research on this, because our studies don't go out that long. But in my experience, what I see is that the buprenorphine seems to normalize things for the pain patients or the patients who've been on opioids, and the body starts healing itself over time, and that's what allows them to reduce later on. But if you don't have them on enough, it's not going to get to the point where they can heal. So it seems like if you underdose them, they're not happy. They have anxiety. They can't sleep. And if you keep them they're just miserable if you underdose them. So we can make buprenorphine fail. We can make, and that was the problem with just taking people off opioids. We really thought we could take people off opioids, and then the suicide rates went up. So, and there's a relationship. We're really, the studies are good now on the relationship between suicides and polygamous opioids. So we can't just take them off. We can't just say, no, we're not going to deal with you, because it's causing deaths in our patients.
Okay, I have a second question that's semi-not related. So my residency program, and I'm out about 5-6 years as well, they made a focus on transitioning patients off of short-acting and onto long-acting if we could not find other avenues of getting them off of opioids. I've been listening intently to see if you would comment if there is a benefit for the long-acting versus the short-acting in the long term for chronic pain management.
Did you want to answer that?
I mean, in the sense of a traditional opioid, or are you talking about buprenorphine?
Traditional opioid.
I mean, my first consideration would be to transition those patients to buprenorphine. That's going to be my long-term opioid of choice.
The thought is it'll keep people from, having breakthrough pain if you put them on the long-acting. And there are some pain specialists that do that, change anybody who's on short-acting to long-acting. However, it does increase risk. And that's why there's some states like Washington that are saying if you prescribe long-term opioids, you have to take more CME courses in long-term opioids because it does increase risk. A lot of patients, even though they're good, I would only do long-term acting opioids if patients are really good about taking them as prescribed. But most of my patients will confess to me after they get to know me that they don't always take them as prescribed. And that's where long-acting opioids become more dangerous, because the patient will start taking several of them because their pain needs aren't met. And then the peak is later and they overdose.
Well, that's actually one of the reasons why the residency program chose to go that route, because for proper monitoring, we were taught that it was more likely to have a appropriate drug screen if you did it randomly. You would take away the need for as-needed dosing, so you have more of a predictable regimen, so to speak. Now, that's not to say that you wouldn't control their pain and try working on the dosage adjustments and so forth, but I don't know. I don't know if you guys found that successful at all.
Yeah, and what I'm trying to recognize in pain management is there's no really wrong and right answers. For me, the right answer is always going to be buprenorphine, because all of everything I know and the studies I've read, I'm just always going to try and get people on buprenorphine. But that doesn't mean it's always the right answer for everyone. So if someone's comfortable with doing long-acting opioids, that's their answer, But I don't find it that really changes the picture that much. If I do long-acting opioids, it's going to be buprenorphine, just like Dr. Agnello.
Well, unfortunately, thank you for awesome questions. We are out of time. We have to end it here, but Dr. Farrell or I will be available outside if you want to ask any other questions. We're going to pick up back in this room actually at 11:45. There is some time right now for exhibits and checking out the scene over there, so please kindly do that. Support those who exhibit here at ACOFP to encourage them to continue in the future. We thank you for your attention. Have a great rest of the morning, and see you at 11:45. Thank you.
I want to thank you all for participating. Yes. It was a great session. I didn't see too many people fall asleep, so that's great.